So now, thank you. Very good morning to you all. I'm a bit bleary-eyed. I only got in at 4 o'clock this morning, so I've had a couple of hours sleep. But looking at all your faces, I feel suddenly reinvigorated and refreshed. My name's Andy Edwards. I'm a consultant oral and maxillofacial surgeon, head and neck surgeon, based in actually England, although I'm Scottish, yes. I'm very proud of it to be Scottish as well. So now, thank you very much for the invite. Great to be back in India. I think it was there. The Asian conference was the last time at the end of last year, which was great, so it's nice to be here. And a new state for me, Gujarat. Yeah, Ahmedabad. So again, thank you very much, and I look forward to interacting for you. So Sonal gave me this thing about variations, and I thought, oh, we're going to talk about here. I'm not going to talk about accessing it and all the ways of doing it. That's been done, yeah? Everybody's talked about it, about the various approaches, the advantages and disadvantages. There's only so many ways you can get into the mandible, yeah? And we've covered them all, yeah? So what I thought, well, Sonal's given me infection, pathology and distraction. So I thought, well, let's maybe think about some cases. And that's what I want you to think about, is some cases and how you're going to approach them and what approach you're going to use. And using what everybody said this morning beforehand, the advantages, the disadvantages, what you're going to use in your surgical practice. So I'm not actually going to talk about the disadvantages. You've seen the videos, you've seen everybody go on about it, so there's no point in me reiterating and reinventing the wheel, basically. So, talk about infection. We all know there are spaces we need to get to, isn't there, in the mandible, related to whether the infection is coming from a dental cause, i.e. a canine or a third molar or something like that. So you've got these primary spaces, and we all know what the primary spaces are. Then you've got the secondary spaces, and these are the ones that we've got to worry about. So if you've got spread of infection going from a primary space to a secondary space, so you've got to think about where that infection is, how I'm going to get to it. Is it in the primary space? Is it in the secondary space? Am I going to use an intraoral approach? Am I going to use an extraoral approach? So again, you've got to remember where these spaces are. And again, beautiful lectures on the anatomy. I'm not going to get in great detail there, but it's just to show you there where the different spaces are in relation to the mandible. You've got your buccal space, submandibular space, pterygomandibular space, and then from there the spread of infection can go inferior or superiorly. And essentially in the mandible you've got two spaces, haven't you? Sublingual and the submylohyoid space there. These are variations on the incisions you've heard of below. You sometimes have to adapt your surgery to where the sepsis is, basically. You can't sort of stipulate and say, right, okay, that's where it is. You need to think a bit laterally, think about your anatomy, and think how you're going to plan your incisions. And these ones give you a rough idea where you're going to get into, whether it be the submandibular, the lateral pharyngeal, or, God forbid, you're either chasing infection down into the carotid sheath or the retropharyngeal region. So these are variations on the extraoral incisions. We've got a classic submandibular space infection, yeah? We've heard about the classic approach of taking 2 fingers. Don't take 2 fingers, take 2 centimetres. My 2 fingers are a lot bigger than some people's 2 fingers, yeah? So be mindful of that. Be mindful here that where that place in that incision is the most dependent point, basically, yeah? You're going to get the most dependent point here, rather than go 2 centimetres. 2 centimetres in a case like this, it's not going to get you anywhere, basically. It'd be great if you want to go to the lower border of the mandible, but we're draining an infection here, yeah? So you've got to be mindful of that. Ludwig's, yeah? We've all seen a Ludwig's. Not nice. But again, think outside the box. Think about the fact, am I going to do a submandibular incision? Am I going to do a midline incision? We know fine that the rudiments of what you've been listening to earlier this morning, you take them now and you can use them and plan your incisions basically depending on where the infection is. So you can see here there are 3 incisions that you've got to make basically depending on which spaces are filled. Again, I'm not telling you how to treat a Ludwig's, but exploration of the space. I put put that slide up there to show somebody ramming a pair of forceps in there, yeah? Don't ram a pair of forceps in there, ram your finger in there, yeah? You can feel things with your finger. You can feel locules. You can feel muscle fibres with your finger, believe it or not, yeah? So use the finger, don't use that as I've illustrated there. And obviously you want to put some drains in as well. That's where we put the extraoral drains. Intraorally, again, your incisions have got to be dependent on where your pathology is or where your infection is. There we've got a buccal space infection, there we've got a sublingual infection, and you've heard about the incisions to get you access there. But you have to modify them, yeah, and you have to modify them based on the pathology of the infection. Pathology. I thought, well, what will we talk about in pathology? Well, let's think about benign pathology and some simple pathology. We've all seen a ranula, haven't we? We've all had a ranula. What's the treatment for a ranula? Yes? Remove the gland, absolutely. Not marsupialise the damn thing. Yeah, it's a horrible operation. What about a plunging ranula? How are you going to deal with that? Hands up, who's going to go in the neck for a plunging ranula? I wouldn't. I go intraorally and I remove the sublingual gland. I've been caught out a couple of times. Again, the anatomy, I'm not going to bore you with, but again, that's your incision. You've got to think about the incision. Rather than make a straight incision, make an elliptical incision. Gives you something to pick up with, basically. So think about a variation depending on what you want to do. In this case, we want to move a gland, yeah? If I make a straight incision, then you've got nothing to pick up with. You've got some tissue here to hold on to, and it gives you something to actually remove the gland with, yeah? Because when you're trying to put forceps on a sublingual gland, it just tears, doesn't it, yeah? So it gives you something to do there, and it gives you something to think about in your closure. And you can see the anatomy there, the duct and the nerve. So what about bony pathology? This is just a simple cyst that I treated some time ago, but again, think about how you're going to get that. So what we're going to worry about with this benign pathology here? Yeah, well done, fracture, yeah, absolutely. So what could we do to mitigate against that? What do you think I could place there? Put something in there. Yeah, absolutely. So what approaches are you going to use? Intraoral and extraoral, exactly. So you've got to think here. This pathology here, there's a risk of a pathological fracture, isn't there? We're going to have to take a third molar out, possibly take out the lower 7, possibly take out the lower 6. That's just a 3D CT. You can see the buccal expansion there. The incisions you've heard about, a clavicular, or are we going to do a vestibular? In this case, a clavicular incision would help because I want to close that oral mucosa, yeah? I want to keep a watertight seal, basically, yeah? And I'm going to be taking teeth out. And I'm going to use an extraoral approach, yeah? Submandibular approach, yeah? So, 2 approaches. I used a PSI for this one, it's a patient-specific implant. That's either here or there, just showing you how went in. And a second one now is, this is a condition of benign pathology. The whole of that left mandible's dead, yeah? So what are you going to think about incision-wise to get rid of that? I'm going to have to take the left mandible out. What type of incision? Can I get it all out in intraoral? No, probably not. I'm going to have to do extraoral, yeah? So this was dead bone, this whole left mandible here. You can see the white out basically. It's just dead. It actually came after a tooth extraction. And you can see there the very thick, dense, dead bone. Again, it was a PSI I designed for her. And again, I'm not going to talk about Sonal and take her, steal her thunder. That's pre-auricular approach. We had to do that, but in this case, just you thinking about how you're going to get in to put in something, basically. In this case, we just done a classic submandibular incision and indeed a pre-auricular. I'm not going to talk about access to pre-auricular, that's Sonal's plan. So, that's the implant going in, basically. When you're doing a submandibular incision, a little technique, don't go down a deep dark hole, broad front, yeah, keep it on a broad front, yeah, because you get lost down dark holes. I've got lost down dark holes, post-op view. About cancer, how are we going to get rid of this cancer? Extraoral, intraoral, or both? Yeah, we're going to do some of that. We're going to come on to lip split, but yes, we're going to have to, some way we're going to have to marry up the extraoral approach with an intraoral approach and using a lip split, and I'm not going to go into that because again I'm stealing somebody else's thunder about the variations of lip split, but it's just to show you the concept of an intraoral incision, using a lip split and using that to continue into an extraoral incision or a neck incision. We'll hear about neck incisions later on tomorrow or the day after. And it just shows you where you get beautiful access there to the mandible. And the reason I want access to the mandible is so I can do this, yeah? So I need even more access, and again I'm not going to talk about mandibulotomy, that's going to come up. It's just to show you the concept of how to vary your incision from an intro to an extra and how to combine the two basically. And that's just a little bit about the osteotomy. I'm not going to talk about that, that's just showing you, but it does show you the access you get, yeah? So I've now combined an extraoral with an intraoral via lip split and a mandibulotomy, and I open up the whole side of the neck, and that can give me beautiful access. So it's thinking about your different types of access. A bit on distraction. I don't do distraction. I have done distraction. And this is just showing you distraction in the mandible, where you can distract. You can distract the condyle, you can distract the ramus, the angle, the body, symphyseal region, alveolar. Method of placement, you can put them either subcutaneous, intraoral or extramucosal or subcutaneous. Again, an intraoral incision is pretty straightforward. Problem with extraoral distractors though is they cause a lot of facial scarring. You can see that as well there. Intraoral, you can get that through a simple vestibular incision, again for doing a ramus or indeed a body, but you've got to remember that you need to create a port for your activation device basically, and that may mean coming through an extraoral approach, not using it all intraorally. And again, thinking about where you're going to plan your incision. And again, just doing that, planning your incision through an extraoral approach, so you can put on the distractor with the activation device coming out extraorally. And again, intraorally, you can do it to get to the angle there. And this is just what was showing a case where we had intraoral distraction. But remember that the activation devices actually had to come out through here basically, yeah. And you can just see the ramus being activated. Or you can put them intraorally basically. My good friend Balaji, that's one of his patients, so I used that basically. So think about access, think about how you're going to plan it, depending on your pathology, depending on infection, and if you want to put a distractor. Thank you very much, thank you.